Welcome to my presentation on delirium. This is a brief presentation by me, Dr. Shibley Rahman. This talk is not to be used for medical or legal advice and always consult a registered clinician. In this talk, I would like to explain what is delirium and actually also consider what might be a person, because this is very relevant to what we know as person-centered care. Delirium is of course a medical emergency and is the cause of many presentations in the acute medical unit. I'll talk about how you might identify a patient as having delirium and some of the non-pharmacological and pharmacological approaches you might take. In my jurisdiction, England, it's important to have a feel for whether a person fulfills the legal criteria for mental capacity, and I'll also talk about the current legal framework for practice, which includes the liberty protection safeguards. I will consider very briefly the relationship between delirium and the dementia syndromes, but I think I will mainly wish to concentrate on the risk factors, causes, and outcomes of delirium, and of course the complications. This has just been newly published and comes into effect, we hope, in August 2022. The Royal Colleges have put together some important learning points. Delirium is included, and they were heavily influenced by the British Geriatric Society recommendations. I'll be following this in my talk. First of all, to kick off, what does it actually feel like to experiencing delirium? Well, I've never experienced delirium other than watching it in my own mother, and it was very scary because I knew nothing about delirium before, even though I was medically trained. This is, of course, a matter of great shame. What happened to me was as follows. At about 4 o'clock in the morning, Mum started making funny noises, and then the rest of the following day, she would be fast asleep or dozing off mid-sentence. And I knew Mum was not Mum. There are different aspects to what it might be like to be experiencing delirium, and I've listed them here. This might include being reluctant to eat or drink, suddenly becoming frequently incontinent, being sleepy, being slow to respond, being able to see things which aren't there, hear voices which aren't present, be less aware of the world around you, or even being very grandiose or manic, worrying people are about to harm you. When I mentioned that Mum is not Mum, I meant that. It's almost as if she's a different person. But let's unpack that a bit. It doesn't mean she stops being a person. Consider this: when a person falls asleep, they're still a person. It becomes complicated when people start acting funny, like in temporal lobe epilepsy, or people are falling unconscious, for example, a hypoglycemic coma. But if you take this to an extreme, if a person stops being bestowed with personhood, this is a very slippery slope, because it means that you ignore human rights. And if you ignore human rights, it's a passport to poor quality care and lack of respect and lack of dignity. Regulators, of course, know this. This is Regulation 9 of the CQC, which emphasises person-centred care. And the issue of person-centred care has been a recurrent theme in geriatrics for longer than I've been born. Here's Mary Tonetti's seminal article on the end of the disease era. And the repercussions of this are very significant. For example, you no longer have a primary focus on the disease. You consider a person in their genetic, environmental, psychosocial, social, legal environment. And in fact, the impairments as they reveal to you are not necessarily primarily focused to a single discrete disease. And an important difference is survival is one of competing goals, but survival is, of course, the usual primary focus of disease prevention and treatment in a disease-oriented model. Other goals include quality of life, well-being. Hospital wars, by their nature, through no fault of people working on them, can be very uncomfortable places for patients and carers. There tends to be a lot of noise, even at night time, with quite a rapid turnover of staff. And there are cultural issues as well, such as nobody or very few people introducing themselves by name. Patients being taken off to investigations suddenly and procedures at random times, seemingly without any warning. Ward rounds often take place with carers absent. Not because the carers don't want to be there, but because the carers can't be there, because they don't happen to coincide with visiting hours. And some of the behaviours themselves are quite dehumanising. For example, keeping people in bed in pyjamas, or even worse, gowns which aren't done up properly, and no mobile phones, or no hospital Wi-Fi. And some of the aspects of the hospital bed are actually quite dangerous, arguably. For example, imagine if you were hyperactive and agitated and you got your arm somehow stuck in one of those bed bars. You would be even more distressed. Delirium is an important and significant medical emergency, and therefore recognizing it is important. It can be due to unintended ageist attitudes be misattributed to other things. And there are repercussions for this lack of recognition. Physicians may not be aware that delirium may be the manifestation of an illness such as stroke, sepsis, or an MI, not because they're lacking knowledge, but because the symptoms don't reveal themselves in a typical way. There is cause for optimism, I believe, in the treatment of delirium, and there are many educational initiatives currently in place, including many quality improvement initiatives. So, trying not to scream, let's think about this. Mum is not mum. In other words, simply ask a carer or a friend, pick up the phone. Do you think this person has been more confused recently? Have there been any sudden changes in behavior? Has he become more agitated? Has he become more withdrawn. Here is a slide from the BMJ, so I will not take credit for that. But it shows there are different types of delirium. Two main types are hyperactive, where you suddenly fall asleep and drowsy and inactive, or hyperactive, predominantly agitated, restless, anxious, increase in motor activity. Of course, the two can flip around. One minute somebody can be hyperactive and another can be hyperactive. So we call that mixed. And there are other types of delirium which are beyond the scope of my talk. Who are they? Well, the person in front of you is Shaun Unui, professor of geriatrics at Harvard, and behind Dan Davis, Dr. Dan Davis, world-renowned eminent specialist in delirium, as well as another specialist, professor of geriatrics in Edinburgh, who's also a world-renowned researcher, Professor Alistair McCulloch, who invented this, a simple assessment tool for delirium and cognitive impairment. And you can see there the four domains of this. Number 1, alertness. Number 2, the AMT4. Number 3, attention. This can be assessed, for example, by months of the year backwards. December, November, October, I think. And number 4, acute change or fluctuating course. Once I would think Mum was vastly improved, and then suddenly she'd be back in delirium. It can give you false hope. And here are the official criteria, if you want them, of delirium under the DSM-5. And here, of course, is the CAM, world-renowned, used all over the world, and invented in Harvard by Shaun Unui and colleagues. And the hallmarks of delirium are defined on this slide. It's important to take a medical history, including the onset and course of confusion. We prefer the term delirium to confusion. The state of previous activity, including ADLs and cognition, full drug history, alcohol history, including sudden withdrawal perhaps, functional activities of daily living, and other aspects, of course, including diet, bladder, bowels, and sensory function, and especially current and past comorbid illness. When I first trained, almost 20 years ago, delirium was sold to me as an acute confusional state. In other words, presenting it as nothing to worry about, move on, and reversible, no problems. But it does cause problems, including falls, pressure sores, immobility, dehydration, social isolation, loneliness, infections, functional impairment, continence problems, oversedation, which can be iatrogenic, malnutrition, and even worse, increased rate of probability of death, cognitive decline, and of course Dr. Daniel Davis has been um, um, really pivotal in showing this, and others. Readmission to hospital, increased hospital length of stay, greater likelihood of being transferred prematurely, I hasten to add, to a residential setting. There are, in fact, some patients who are thought to have dementia who, in fact, have delirium for a very long time. This is called persistent delirium and is a cause of major problems. Decreased health-related quality of life and a decline in activities of daily living. So it's probably worth us considering possible outcomes of delirium, and one is the patient experience. It's not uncommon for patients who've been on the ICU to experience PTSD, trauma, stress, and for them they can have flashbacks and sensory disturbances, and they need help. Other outcomes include falls, subsyndromal delirium. What's that? Well, that's delirium which is not full syndromal delirium, a sort of more sinister type of delirium, a sort of halfway house, neither normal nor delirium. Cognitive impairment, psychiatric symptoms such as depression, transfer to a care home, disability, transfer back home. Of course, that can be a very happy outcome for many. Post-ICU syndrome, readmissions, and death. Delirium expert Dr. Thomas Jackson in Birmingham has done this very useful graph, and for me it shows that delirium is also above all archetypal frailty syndrome. In other words, people don't quite bounce back fully after it, sometimes, often, quite a lot of the time. And there are advantages to planning in care for patients at an early stage and access to a prompt diagnosis. If not addressed, delirium can in itself predispose to pathology, other disease expression, increased frailty. So above all, world physicians in delirium want to adopt multi-component interventions, which are a heterogeneous group of measures that typically target multiple delirium risk factors in a systematic manner, including orientation, mobilization, in others walking, the rest of us, pain control, prevention, optimal hydration and nutrition, regulation bladder and bowel, and oxygen if safely given and required. Well, riddle me this, if you happen to have delirium and you're not with it, would you necessarily take the polythene off a microwavable hospital meal? I wouldn't. And after 10 minutes, you could find a HCA fine it's been totally untouched, and so might be reported back as patient refused. But in fact, the lack of food and water could mean the delirium gets worse. Other aspects of suboptimal delirium care include catheters, bed bars, restraints, sedatives, ointments, movement of patients to foreign wards, constipation, and drugs. And here's a rather lengthy example from a paper about how poor communication can be, and it can be a struggle to receive information even if you ask for it. And this can be especially bad sometimes in a hospital admission, although I have witnessed with my own eyes some very good communication from doctors. And I made a list of possible ways to support communication, including using a calm and gentle, friendly approach, and using verbal and non-verbal ways of reassuring people, making the patient feel as if he is in control, and avoiding arguing, understanding and having respect for the person as they were known to people before the admission. And the list of presenting issues in delirium have been addressed previously by me in this talk, but I want to just put them up here again as a reminder. Delirium is different from dementia. At worst, I've had delirium explained to me as an acute exacerbation of dementia. That is wrong. That implies that it's a sudden pathological acceleration of what was causing the dementia. And it also implies that you don't realize it's delirium. Here is a comparison of dementia and delirium, and the thing I would really like to emphasize is the onset. Delirium is sudden, acute to subacute. Dementia is gradual, over months to years, and worse, weeks. The course can be variable, hard to predict in delirium, with fluctuating symptoms, often especially worse at night. But in dementia, symptoms tend to be gradual, long-lasting, progressive, and some relatively stable over time. But it's worth you familiarizing yourself with the differences between delirium and dementia. For example, attention can be fluctuating in delirium, but can be normal or slightly diminished even grossly in dementia. And here are some further differences between delirium and dementia. What is it that triggers delirium? Well, many things, which is why a general physician needs to have a expert look at it, such as dehydration, decreased amount of sleep, constipation, anemia, endocrine problems, hypoglycemia, surgery, pain, pressure ulcers, suddenly stopping a drug, alcohol, and underlying predisposing factors might be lurking behind. It's worth you looking at them carefully. One is cognitive impairment or dementia. Suddenly, delirium can unmask an underlying dementia. This is worth looking out for. Delirium is complicated, I know that, and in fact, even worse is the brain consists of billions of neurons, nerve cells. So I would warn against an overly reductionist, simplistic view of delirium. Although it has been approached pharmacologically through manipulation of single neurotransmitter or neuropeptide systems in the main. And there's a lot of evidence about this. Look, for example, at the recently published SIGN guidelines from Scotland. They recommended all patients at risk of delirium should have a medication review conducted by an experienced healthcare professional. And here is a Cochrane review from 2018. Key findings were as follows. We found no evidence, they say, to support or refute the suggestion that antipsychotics shorten the course of delirium in hospitalized patients. Based on the available studies, antipsychotics do not reduce the severity of delirium or resolve symptoms compared to non-antipsychotic drugs or placebo, or lower the risk of dying. And here is the guideline in case you want to look at it. I strongly suggest you do have a look at it. And delirium matters to me on a very personal level because it caused me a huge amount of distress as a carer. Here's my blog. And I suggest we capture the value of stories in delirium. And here are various models relevant to narrative analysis. And the more papers we have on this, the better. The law is a very important tool, and mental capacity is often badly understood by people. The Mental Capacity Act of 2005 is based on 5 key principles. Principle 1, presumption of capacity. Principle 2, individuals being supported to make their own decisions. Principle 3, a recognition of decisions which may seem too unwise but are legitimate to the person making them. Principle 4, best interests, and Principle 5, less or least restrictive option. Under the Mental Capacity Act, a person must be assumed to have capacity until proven otherwise. And capacity is decision and time specific and may fluctuate throughout the course of an admission. The law is changing, however, and the newly introduced liberty protection safeguards may be applied to delirium, although the case law on this is yet to be fleshed out. Deprivations of liberty have to be authorized in advance by the responsible body. And for the responsible body to authorize any deprivation of liberty, it needs to be clear that the person lacks the capacity to consent to the care arrangements. The person has a mental disorder, and the arrangements are necessary to prevent harm to the cared for person and proportionate to the likelihood and seriousness of that harm. So I hope this talk has been useful. I've tried to explain what a delirium is and explored a little bit about what person-centered care is. I've emphasized that delirium is a medical emergency, and I've looked briefly at the importance of prompt identification of it. I've gone on to talk about pharmacological and non-pharmacological ways of intervening, as well as assessment of capacity where necessary. Finally, I considered the relationship of delirium to the other syndromes, including dementia, and I also looked at risk factors, causes, outcomes, and complications of delirium. Thank you for listening.